Welcome to the SIBO Doctor podcast with Dr. Nirala Jacobi. If you're a practitioner and want to learn the basics of SIBO, head over to sibotest.com and sign up as a practitioner. This will give you access to a free 90-minute webinar on the fundamentals of SIBO treatment. If you're a patient, please know this information is not intended to diagnose or treat a medical condition. Please ask your doctor before initiating any new treatments. And now, over to Dr. Jacobi and the SIBO Doctor podcast.
If you're like me, you're finding that treating small intestinal bacterial overgrowth can be complicated. Patients often present with a myriad of symptoms and associated conditions which require holistic thinking and a methodical approach to treatment. This podcast was born out of a desire to start a conversation with other practitioners, educators, experts, and researchers, and see if their insights can give us new treatment considerations, especially for our difficult cases. In this podcast series, our guests talk about functional gut disorders, hormonal issues, the enteric nervous system, food intolerances, the immune system, the microbiome, methylation and genomic issues, and everything else that can make a SIBO case very confusing. I believe that by understanding the often complex interconnection of SIBO with other disease manifestations, we can be more effective in our treatment approaches. I hope you find this podcast useful in your practice, and thank you for listening. So welcome to this episode of the SIBO Doctor podcast. And today I have the great pleasure to be speaking to Heidi Turner, who will be talking to us about Mast Cell Activation Syndrome. Heidi Turner is a medical nutrition therapist at the Seattle Arthritis Clinic at Northwest Hospital UW Medicine in Seattle, Washington. She counsels those with autoimmune, inflammatory, and degenerative diseases in an effort to decrease their pain through dietary change. She specializes in food intolerances, SIBO, and other digestive disorders, Mast Cell Activation Syndrome, Histamine Intolerance, and natural food chemical sensitivities. Heidi earned her master's degree in nutrition from Bacterial University in Kenmore, Washington, and completed her dietetic internship at Virginia Mason Medical Center in Seattle. She's the creator of Elimination Diet RD.com, a website that educates on food allergies and sensitivities, and has authored 3 elimination diets for various inflammatory conditions. And Heidi and I are both speaking actually at the 2017 Integrative SIBO Conference in Lombard, Illinois next March. And I saw her on the schedule, fascinated by the topic, and thought, gosh, I've got to speak to this woman. This sounds so fascinating. So Heidi, how did you get into this disorder, and tell us more about it? What is it?
Sure. Thanks for having me, by the way. I'm thrilled to be here today. I came upon it quite accidentally, I would say. I've been the nutrition therapist at the Seattle Arthritis Clinic for coming up on 10 years now. And, you know, the longer that you work with one population, so it's primarily an autoimmune population. I work with 8 different rheumatologists who send their patients to me to see if diet makes a difference in terms of changing their inflammatory process and their pain. And so, you know, the longer you stay with one population, the more patterns that you start to see. And these patterns started to see more issues, not just with standard, you know, joint pain and swelling, but then you would see that correlated with digestive issues. And then I would see more allergy type issues associated with not just the joint pain and the gut pain, but also with the allergy issues. And so I started to see this combination of symptoms that no one was able to really diagnose. And you would look at their blood and it would be perfectly fine. The CRP would be fine, the SED rate would be fine, but the patient was in just acute distress. And many of the rheumatologists that I was working with couldn't figure out. They'd been from specialist to specialist to specialist, and they hadn't really been able to get any solid diagnosis. But all of them tended to have this combination of symptoms. And so the more I started working with the gut, the more I started working with bacterial overgrowth and dysbiosis, I started working more. One of my patients came in and told me that she was diagnosed with mastocytosis, which is a mast cell disease. And I had never heard of it before. This was about maybe 8 years ago. I'd never heard of it before. And I started looking into it more and looking at her symptoms and then seeing how she had chronic migraines, she had severe IBS, she had severe swelling and all over joint pain. She'd been given a diagnosis of fibromyalgia. And I started to see similarities between her and many of these other patients that really didn't fit within any particular category, and started looking at them and asking the doctors to measure serum tryptase levels and different diagnostics that could give us an indication that we were working with mast cell disorders. And lo and behold, many of these patients fit within this category of mast cell activation syndrome. And so bit by bit, I just see more and more patients coming through that have this condition. And, the more you work with this population, then the more patterns you find in terms of how they respond to treatment, what treatments they don't respond to, what are the common causes. You just start to see those patterns start to come up. And so it came quite by accident, but it's been a really, really interesting condition to work with.
Yeah, and I see, oftentimes when I see people with really long-standing SIBO, they have a lot of they have a lot of food intolerances, but they also have a lot of systemic symptoms that go beyond just, sometimes it is leaky gut, because SIBO obviously can cause leaky gut, can also cause inflammatory conditions because of its release of IL-6, but also one of the features that can occur in SIBO is mast cell infiltration into the mucosa. So can you give us just like a brief primer on what mast cells do and what triggers them?
Sure. Yeah, sure. Yeah. So mast cells are just these little vesicles that are part of our immune system, and they're strategically placed throughout the body, usually in areas of sort of frontline protection. So they're in higher concentrations in the skin or the eyes or the nose or the digestive tracts or lungs, things that are more exposed to the outside world. But they also can roam through our bloodstream. They can be found in the brain. They're found in a variety of different tissues within our body. And so they're typically involved. What we typically associate with mast cells is more allergy type symptoms. So they're typically involved in allergy or IgE mediated response. So, for example, let's say you have a peanut allergy. You have these IgE antibodies that are always on the lookout for peanut proteins coming through because the body's determined that peanuts are a threat. So once that peanut protein is detected, these IgE antibodies, they bind to that protein and they present that they bind to these mast cells, and that then triggers the mast cell to essentially explode and release its contents. And these contents are histamines, which help to usher the immune system to the peanut protein, and then other immune system mediators, heparin or cytokines, which are designed to attack and defend the body from the offending allergen, in this case, the peanut. So, this reaction causes a lot of swelling and irritation and inflammation. So if it's a mild mast cell response, then we end up with more, snotty, sneezy nose or urticaria, hives, itching. We get a lesser response. And then if it's a larger response, so we have a lot of mast cells reacting, then that can be more serious. We can end up with anaphylaxis. So that's your normal mast cell immune response. So with mast cell activation disorder, we also call it MCAS. With MCAS, these mast cells are being triggered by causes other than that typical allergy response. And these mast cells are either being triggered to explode, or they can actually just leak their contents into your system. And this then triggers an immune response that can create all of a myriad of symptoms, that are related to systemic inflammation. The symptoms that we might typically see would be things that we might typically associate with allergies. So, skin issues like hives or angioedema or flushing. We might get more GI symptoms like nausea or diarrhea or abdominal cramping or vomiting, cardiovascular symptoms, respiratory symptoms. So, or like runny nose, itchy eyes, postnasal drip, those type of things. So those can be some of the symptoms that you can experience with the mast cell activation disorder. But We can also see, I work in a rheumatology clinic, so it's also really common for us to see a lot of joint pain or swelling, chronic fatigue, migraines, body temperature fluctuations, or severe weight fluctuations.
Really interesting. So how do these conditions do they develop, or do people have a predisposition, a genetic predisposition, and then something kind of throws them over the edge and triggers the onset of this condition? Or can it occur in conditions like SIBO, where you have just a lot of dysregulation on a small intestinal mucosal surface?
Well, it's a good question. I think it's difficult to say. Of course, genetics are always going to be a piece in this. We always have a predisposition. I'd say the majority of my patients had severe allergies, or at least allergies as a child, that they might have outgrown. So there's usually a history there, or that they might have developed as an adult. So there's usually a history there of some kind of allergy that they were experiencing. So I think that there's a past history. I think there's a genetic piece. I always think there's a microbiome piece.
Right.
Which means just the bacteria that exist. I think we're just a combination of our genes and our bacteria, basically.
You're right.
There's that predisposition is what kind of bacteria do we have in our gut? But honestly, I would say, because all of the patients that I see, everybody is so completely different in their presentation. There is never one same MCAS presentation. It's just more of a combination of symptoms that one might experience, but everyone is presented differently. But what I would say is, like, the thing that everybody, I would have to say, I can't think of one where this wasn't the case, is that the onset of their symptoms occurred during a very severe and prolonged period of emotional stress. And in many of those cases, there is also a component of past history of trauma, whether that was childhood trauma or some sort of physical trauma or sexual trauma, something that gets re-triggered again once that stress gets going in their adult life, that we can see that this is something that I am observing within my patient population, but that the stress of now triggers. What's interesting is the mast cells, they have these receptors on them that for corticotropin stimulating hormone, which is the hormone that we release when we're stressed. So when we release that, we can trigger that mast cell to activate. And even when that stress goes away and life goes back to normal again and everything calms down again, we can't turn off that reaction. And in many cases that I have seen, there is a level of past trauma that has been unresolved. And what I question in this is whether or not it is that past trauma that has now been reignited that continues to keep that mast cell continuing to leak or get triggered or explode or whatever it's doing. So that is a really common thing. I talk a lot with my patients about trauma, and I'm always referring them out to practitioners that can help them to manage that and go back to it. And in many cases, we see improvements by going back to that place. So stress is a huge piece. And now that can be, so not just, past stress, but current stress. That can be physical stress. So getting into a car accident or having a severe surgery or an infection. So, the stressors aren't just emotional. It can also just be a physical stress that someone experiences as well. But I would say every single timeline, every single story that I have seen related to MCAS, the trigger was a prolonged, stressful situation going on in a person's life.
Well, and how that sort of relates to SIBO, perhaps on some level, is I do see definite correlations with certain patients of mine that also have that. I mean, like that level of stress and emotional trauma and ongoing emotional stress, that's pretty much devastating on every body system, I think. So it's not unique to SIBO or MCAS, but I think that one of the areas that I work with often in my patients as it relates to SIBO is really working with the enteric nervous system, because corticotropin releasing hormone also reduces secretory IgA and does all these other mucosal down regulations or up regulations and really affects the microbiome. So I'm always looking at sort of the big picture of what's really going on here. So this part is really fascinating to me to think about this other aspect to the immune system, because I do have some patients where I suspect that they have mast cell activation syndrome because they're just so sensitive. And this is beyond just histamine intolerance. I understand why histamine intolerance would occur in SIBO because diamine oxidase is on the little microvilli, and that often is damaged in SIBO. So I understand that. But can you tell us just a bit more about some of the common causes and contributors to how you can, besides the trauma, are there any things that how they relate to SIBO? So maybe bacterial, you mentioned the microbiome. Is there any evidence that bacterial dysbiosis or SIBO can potentially trigger something like this?
I looked for this. As I started getting more into SIBO, I really started getting, because everybody, and the other thing that's common within the MCAS population is the gut is almost always on. So, and that makes sense because we have those mast cells that exist within the gastrointestinal lining. So the gut is always an issue. And I started looking and I started testing all of my patients who had MCAS. I started hydrogen breath testing all of them to see if they have SIBO. And I have to say the prevalence was really low. I was surprised.
Yeah, that's interesting.
Here it is. I found it. It's SIBO.
Yeah.
And unfortunately, I didn't see much of it. For those who did, treating a SIBO did shift down some of their symptoms, whether that was gastrointestinal or whether that was systemic. So for those who did have it, then sure, absolutely, it's impacting things. But again, it was a pretty low prevalence, so I haven't been able to really, see much benefit through treating SIBO with that population. Now, dysbiosis, I think, is different. Dysbiosis, that's not bacterial overgrowth. That's just more everything's, off in the gut. I see a little bit more of that. And I do see working with probiotic in that population to be beneficial. But it's one of the things about this population, you touched on it, is how sensitive this population is to everything that comes through the gastrointestinal tract. It's a very challenging thing to get it past that immune system. It seems to be on to everything that you put in. And you have to be really careful about how you administer anything to this population. This would be another indicator of maybe whether a patient might have MCAS. And there's a diagnostic criteria, but an indicator is that this patient reacts to everything. I'm giving them this medication and they're reacting to it. And they get all the side effects to it. And then I give them this supplement and they react to everything, and all the side effects to it and that you've never seen before. So you have to be really careful about how you administer anything to this population. But coming back to the microbiome piece, coming back to the dysbiosis, is I typically don't see very good tolerance to probiotics. Just like you might see intolerance to probiotics in SIBO, I don't see very good tolerance to probiotics. I'm very careful. I can count too many times how many times I've given a patient a probiotic and it just triggers a response that can take weeks to months to resolve. And so I'm very, very careful about how I treat that population. And, some people are more sensitive than others. There's a real broad spectrum here. So I typically work with single strain probiotics. I work with ones that typically, have been shown to reduce histamine as opposed to produce histamine in the gut. I always start with very small amounts. Sometimes I can only get in the one that is universally accepted, that I've seen almost everybody, and that includes SIBO as well, that the probiotic that I typically see very well accepted is not Lactobacillus GG, but Bifidus infantis.
Okay. That's also a strain that's often used in SIBO and hypersensitivity or abdominal hypersensitivity. So is it like, do you use just that particular strain specifically to down-regulate histamine, or, how do you use it?
I use it because it's the only thing I can generally get in, A.
Okay. So it's the most tolerated, yeah.
It's tolerated, yeah. I mean, I don't know if I've had one patient actually not tolerate it. So it is one, and that's saying something because, I'm always, we're always as practitioners giving them things. There's always reactivity. It's the one I can almost guarantee there's going to be little or no reactivity to. So I give it because I know that it has the potential to at least reduce histamine response in the gut and reduce hypersensitivity. I don't know if you have it in Australia. It's called Align. And so we have that here in the United States, and it's actually released by a pharmaceutical company here. It's the only way for us to get a single strain of Bifidus infantis here. And so you can get it at any grocery store, any drugstore. It's only 1 billion strength. It's also a very small amount of probiotic, but it's the one that I could at least start them on. So if I've tried other things and they're not they're reacting to them, I can start them on that because I know there's going to be tolerance. And after I've had them on them for a period of time, I can generally get another strain in. And then and again, always single strain. And then, I do see symptoms start to shift, but it is a long, long process. So I know that the dysbiosis is a piece in this mast cell activation disorder. Now, whether it was a mast cell activation disorder that triggered more of the dysbiosis, or was it the dysbiosis that helped to trigger the mast cell activation disorder? It's difficult to say, but I know that it's an issue. I'm working with a patient now who we've been able to build things up with her as far as we had to start with a line and we built her up bit by bit. And she had to take antibiotics for a sinus infection, and it just ruined everything. And we were seeing things start to shift. Like we were getting obesity is part of her mast cell activation, and severe migraine is part of that. We were seeing shifts happen as we were working with the microbiome. And she went away from treatment for about a month for me, and she took an antibiotic in the middle of that and came back in, and everything had reversed. The weight had started coming back up again. Migraines were back up again. Everything was starting to shift. And so we're starting over again. We just have to stop. We start over again. And hopefully it won't take
so frustrating, isn't it?
It's so frustrating.
Yeah. Well, I think
you get the idea. It's a very challenging.
Yeah, they are. And, one of the things, I guess that's why I was so interested to talk to you, because like I said, I do see patients that I don't know if they have mast cell activation syndrome or not, because it's really difficult to diagnose, right? Even serum tryptase are not always accurate, or you have to go through some really acute flare before that test is accurate, as far as I understand it. And so, but what I do see in my patient population, and when you specialize in SIBO, and this is what I've already said on previous podcasts, it's just like you just see the most sensitive of the sensitive, because they are not being helped by anything. So, I have a suspicion, and perhaps these people don't have MCAS, but they have they do have to some extent reduced their diet so severely for so long that they have also preferentially fed a particular bacterial population. And so and I always warn my patients that, if I'm going to introduce something, you will react. It's just nature of the game, because you are going to now feed a different population of bacteria, and there's going to be some resettling. So I always give my patients... That's an
interesting perspective. Yeah, interesting. Yeah.
So, of course, we don't want to flare up for months, and I have to tread so super carefully. Do you think that a lot of these people that have, reduced their food intake to 5 foods because they're reacting to everything, and whether that's salicylates or histamines, I do see a lot of people with salicylate sensitivity, and I do also link everything back to a severe dysbiotic event, or so not just SIBO, but SIBO just being so disruptive to the mucosa, to the integrity of the mucosa, that I do think that's a major player. So do you think that a lot of people that restrict themselves so severely maybe have a sort of a milder or some level of MCAS, or is that involved? Or do you know what I'm trying to say? Is this just only MCAS that has all these features, or are there different, MCAS light? Or
MCAS light.
different levels.
I feel like there's a spectrum, and I feel like the spectrum, I talk about this about my patients a lot, and I feel like I look through this lens of this spectrum. I feel like there's histamine intolerance, which I feel like is the lower end of the spectrum. And for those who aren't familiar with histamine intolerance, this is a situation where the body is building a certain amount of histamine to we build histamines for different reasons. It's not just in relation to allergy, but they're part of our neurotransmitter system. They're part of our circulatory system. They're part of our digestive system, and but some of us build too much histamine and we overload our enzymatic pathways. And there's a number of reasons why that can be, but by shifting, and we end up with all of these kind of allergy type symptoms that can be in the gut, and it can look a lot like MCAS. It can look a lot like that. But by changing the diet, by putting the patient on a low histamine diet, or, even sometimes just a gluten-free diet, by shifting things around, then we can pretty much resolve things fairly easily, right? I feel like if it's just a matter of taking a few things out or targeting a certain pathway, and we can resolve the symptoms easily, I feel like that's sort of the easier end of the spectrum. That's the light, right? It's not necessarily, I don't feel like it's part of the MCAS piece, right? Then I think as it moves up the spectrum, then we move into that mast cell activation situation where, you might get benefit from taking foods out of the diet like histamines or salicylates, but we still have a certain level of activation going on.
Right.
So what are all the other pieces that we're missing here? Like what's been triggered? Why does the immune system still think it needs to be in this fight or flight situation?
That's really interesting, right?
Yeah, and then you move, and then there's different severities of that, to the person who just needs to maybe take 10 foods out of the diet, to the person who only has 5 or 10 foods in their diet. And, then it goes over to the person who has mastocytosis, and that's on the very end, the other end of the spectrum. And that's the patient just is building too many mast cells. And those mast cells are getting triggered, and it's a combination of overload of mast cells, overload of activation, and it's a very, very challenging thing. That's where we're really getting into, enteral nutrition, where, tube feeding, right? I mean, we're really getting into a situation where nothing's coming through that digestive tract. There is no way nothing's coming through that immune system, because it is just going to block everything out. So I'm always kind of working with this degree, and I can generally determine based on what kind of food sensitivities we're working with, the severity of the food sensitivity, the type of food sensitivity, and then the severity of symptoms.
I was just thinking about like the spectrum of presentations that this can take in terms of, our patients that we see so frequently with SIBO, always trying to tie it back to that. So what, if I can just sort of not summarize, but maybe just so that I can get clear about it. So you can have histamine intolerance that might be triggered by SIBO as an example. Sure. And the spectrum can go all the way up to not just mastocytosis, but MCAS being sort of the pinnacle of that. And somewhere on that spectrum, it's an ever increasing intensity of not just symptoms, but also difficulty or a degree of difficulty of treatment. Would that
Absolutely.
Yeah. Okay.
Absolutely. And what I find with SIBO is that for the patient who has histamine intolerance that is being triggered by the SIBO, so the SIBO is keeping the gut in such an inflamed state that we lose that diamine oxidase, which is the diamine oxidase, DAO, is the enzyme that helps us to break down our dietary histamines. So in most cases, when we treat the SIBO, the histamine intolerance, which is the intolerance to the histamines that are in our foods, typically that shifts down. I mean, that really shifts down considerably. And once we start to shift that level of histamine down, then we can see those symptoms start to resolve or at least reduce systemically. But if, we're treating the SIBO and we now have a negative hydrogen breath test, but we still have these other symptoms then there's another pathway to be considering. Now, are we working with MCAS? Because we're still looking at all these, but you have to look at the other symptoms, right? Are they histamine mediated? Do they appear to be histamine mediated? Are we getting the wheezing? Are you getting the urticaria? Are you getting the rhinitis? Are we looking at other things that are potentially mast cell activated that is going to then indicate, okay, the SIBO's down, And maybe we don't even have histamine intolerance anymore, but we still have these symptoms. So now what do we do? And then it's a matter of, okay, do we need to modify the diet more? And that's where we get into salicylate intolerance, and we get into other things that maybe there's a different pathway that we're working with. Do we need to work with different supplements or different medications that are at least going to help to shift some of these symptoms down? Like, where do we need to go from here? So that's the difference, I think, between like just that SIBO histamine intolerance to, okay, that's cleared up. And now what are these other symptoms that are still left? And how do we manage these? What is this?
Right. So can you tell us a bit how to diagnose the different levels on the spectrum? So from simple histamine intolerance, I don't know if you would test for that or just presumptively treat and by removing histamine containing foods and maybe supporting the body a little bit with diamine oxidase and so forth, and all the way to mast cell activation syndrome. So how can we best assess our patients for these?
Sure. So with histamine intolerance, that's a little bit more straightforward. Actually, most of my patients, if they're presenting, I'm seeing a lot of histamine-mediated symptoms, then one of the first things that I'm doing is taking them off of histamines. Typically, the foods that are high in histamine are typically highly fermented foods or aged foods. And then there's a number of other fruits and vegetables that are also elevated in them. But those are primarily those really highly aged foods. So we'll take them off of that, see how they do, see if their symptoms reduce. If they do, then from there, I'm going to be thinking, okay, do we have small intestinal bacterial overgrowth? What are all the pieces that could be contributing to this histamine intolerance? So I look at environment. What did they just move into a new place? Is there mold in the house? What's going on from that perspective? What are all the pieces that could be impacting the production of histamines? I'm looking at hormones, hormonal fluctuations. So we typically see as estrogen fluctuates, we'll see histamines fluctuates, and then we're working with the diet as well. And then I'm also looking at the bacterial balance of the gut. So, and then I'm also looking at their stress levels, which again, that comes back to histamine intolerance. So generally, and then, DAO, sometimes so there's a supplement, it's called diamine oxidase. You can actually give them DAO and it can help them to break their histamines down in their food. It really depends upon the person whether this is helpful for them or not. It's a very expensive supplement. Some people don't want to invest in it. It's about $1.50 a pill. And so some people go, I'm good. I'll just do something else. But for those who do invest, I see it's about a 50-50 split. Some people it works with, some people it doesn't. I do try to give them supplementation that can help to reduce histamine production, quercetin. I'm using something called All Clear, which is a quail's egg supplement from Integrative Therapeutics that I'm in love with right now.
I've never heard of that
I love
one.
this stuff. Oh, God. I just love this stuff. It's Integrative Therapeutics just put it out in the last year or two. And it's from quail's egg. It is powdered quail's egg, and it's been used in Chinese medicine as an antihistamine for years.
Wow.
And they finally got it into a pill form. And I see this it's one of my ace in the holes right now. I can just go, take this, and
they're okay. Like even if they have egg allergies and stuff, they can tolerate it.
It depends on the person. So I'm very careful about that. So I'm always, will try a little bit and see how they do. But most people so far have been okay with it. So I've only had one where they just didn't feel right. And we went, okay, forget it. The only downside is it has xylitol in it, which is, can feed SIBO. It's a sugar alcohol so far, because it's such a small amount. So far, people have been okay with it. So, and I've gotten more benefit than adverse reaction to it. So, I tried different supplements to help to moderate the histamine process. I give, supplements that help to build more DAO like B6. And so I try to just, it just depends upon what they'll tolerate and what's helpful to them. Vitamin C, some people take that high, we'll give them 5,000 milligrams of vitamin C a day and they'll just see significant benefits. And then the next person notices absolutely nothing whatsoever. So, it's kind of that not everybody's built the same here. So you just kind of have to have a toolbox with which to, dig into and try different things. But the idea is that, shifting down those histamines, may be enough just through diet, through stress management, may be enough to really get them to a good baseline so that, things can calm down enough so that eventually we can, and if we find that there is SIBO, we treat that, we can eventually get them back to, a more varied diet and shift things around so that they're actually feeling okay again. So that's more that histamine intolerance piece. Then we get into the MCAS piece. And, I'm doing similar things, but when we're working with MCAS, I'm bringing potentially more medications into the situation. And this is where working with our rheumatologists is beneficial. Working more with antihistamines and mast cell stabilizers. The antihistamines that are typically recommended, and I'm very wary of antihistamines. I know the research is not good right now as far as looking at the risk for Alzheimer's disease. Mm-hmm. So you have to be very careful about overwhelming the patient with a lot of antihistamines. However, for some people, we might need a certain amount of antihistamine to help them so that they can feel functional in their daily life. So, we can work supplementally, but a lot of people with MCAS don't tolerate those supplements very well. Mm-hmm. And they typically tolerate the medications a lot better. So this is maybe where, we're working with different dietary strategies. We might be working with, taking out the histamines in the diet, but also looking at salicylate intolerance to see if that is impacting anything. But we would also work with different antihistamines, H1, H2 blockers, leukotriene inhibitors, different things to see what's going to work. Sometimes hydroxyzine is helpful. And then working with mast cell stabilizers, I actually work with those quite a lot. That's your ketotifen, which helps more systemically stabilize mast cells, and then cromolyn sodium, also known as gastrocrom, which can help to reduce the mast cell. It's more of a mast cell stabilizer in the digestive tract. Mm-hmm. So for some who have really severe, where they're at those 5 foods and, they're at chicken and rice and green beans, mm-hmm. because I see that a lot.
I do too.
Mm-hmm. And we can't, it's not SIBO, and we can't figure this out. It's not histamine intolerance, and they're not tolerating anything we're giving them. Sometimes that cromolyn is like the game changer. It's enough for us to be able to just be able to actually feed them again so that we can figure out everything else that's going on to stabilize.
And is that like, because I know in America you can go into the, chemist and get over-the-counter cromolyn sodium, which we can't do here in Australia, but is it prescription strength cromolyn sodium?
It's only prescription here. Yeah.
Oh, so oh my gosh! When I left, you could get it over the counter.
No, you can do the nasal cromolyn here, but you can't do gastrocrom. It's very expensive. It's about $900 US for a 2-week supply.
Oh my goodness!
Oh yeah, it's very expensive. So and that's come up over the last 5 or 6 years of just and a lot of insurance companies aren't covering it. So I'm not able to use it quite as much. But ketotifen is something that's interesting. That's not available. It's not FDA approved here in the United States. It's not available here in the United States. But compounding pharmacies are offering it up here. And so that is one that I'm seeing better tolerance to, for one thing. Cromolyn was 50-50, and I've seen some terrible reactions to cromolyn, just as equal to the wonderful benefits to cromolyn. I've seen terrible reactions to it as well. Ketotifen, I see fairly good tolerance, and if it works for you, it works tremendously well. It's just terrific.
Great. I'll have to look into that, because I have some patients that were referred to me by their GP, and I'll just talk to their GP about maybe trying that out. Is that a fairly low-risk medication?
Yeah, very low-risk medication. Okay. It either works or it doesn't. It's really, if you, Dr. Theo Herides, he's the primary mast cell specialist. He does most of the research on this. And if you follow his work, he says basically it's not a mast cell. We've called them mast cell stabilizers for a long time, and he's saying it actually is not a mast cell stabilizer. You can actually get some cytokine leakage with them, but he will use a combination of ketotifen, because he finds it to be the most effective. He doesn't use cromolyn at all. He uses ketotifen, and then he has a product called Neuroprotect. It's a supplement, and it's a combination of quercetin, luteolin, and rutin. Okay. And it's a highly absorbable form of these 3 polyphenols. And he finds that those 2 things together in these concentrated amounts that he has in his particular supplement can, really help to stabilize that mast cell. And he has found in his research that quercetin, luteal, and erutin together are true mast cell stabilizers. The issue with those three, he says, is that the absorption is very low. So he's formulated it in such a way that the absorption is higher, but you need to take a lot of it. And it's rather expensive in order, to use his supplement. It's rather expensive, and again, not a lot of my patients want to invest. And so it gets challenging to know what's effective and what isn't, just because cost is always an issue with all of this. And it just depends on who has what. Yeah, exactly. What resources do you have?
So what was this researcher's name, Dr. Theo?
His name is Dr. I love his name, Dr. Theodore Theoharides. And that's Theoharides. And his website is... it's mastcellmaster.com.
Wow.
And he's got,
Alrighty.
Telling it like it is. But he, if you go to the mastocytosis, there's an annual mastocytosis conference, and they have regional conferences, and he's at all of the conferences. But he really is. He's the guy who's doing all the research on this. This is his thing.
Interesting.
And so any of the research that's being done, it's usually Dr. Theoharides has his finger in it somehow. But he's really just really brilliant guy, and so he has this. He has two. He's got the mastcellmaster.com, and that's all the research that's been done on mast cells, and it's just a terrific. If you want to know more about this, that's where you go, is to his website. And then he has his supplement line as well called algonaut.com, I want to say, and all of that's through his website as well. And he's got there's the Neuroprotect, but then there's also a cream, a polyphenol cream that he has for pruritus and eczema. So he definitely straddles both complementary and allopathic fairly well. So I appreciate, learning more from him. He's got a good perspective.
Okay, great. So how do you support somebody specifically for mast cell activation syndrome? Or is, like you mentioned before, there's a huge spectrum of individuality there. So is it any different approach than we would take with histamine intolerance? Or do you start just elimination diet, or how do you approach a patient like that?
Yeah. Initially I want to make sure that there's no one food trigger, like gluten, that's been missed. Because, these kind of symptoms, it can be one food. It can be the gluten, and that could be it. So we're done. Goodbye, right? Or the dairy.
Genius. Just genius.
Exactly. We're done. Goodbye. Have a nice life. But I have to say, by the time people usually come to my office, I'm generally, oftentimes I'm the last stop, because they've been specialists. They've been on the internet. They've done the elimination diets. They've done a lot. So usually by the time they get to me, they've already done a gluten-free diet or a dairy-free diet or an elimination diet. If they haven't, then I would like to just start from just scratch and go, let's just do an elimination diet, standard elimination diet. Let's just see, is it just one thing? And if they're up for that, great. And if not, then let's just look at the diet and see what the major, potential inflammatories are within that diet. Or they, if they're eating gluten every day and dairy every day and corn every day, then let's just, look at the things that they're doing on a regular basis and take those things out. So, keep it easy for the patients, because we may not need to go down this mast cell road. And then, because, I'm a dietitian, right? So it's like that food is my medicine. It's how I work. So I really understand how difficult it is to make dietary changes. So I really try to, the least amount of impact on the patient's life as possible, but I really leave it to them. I educate them. I say, here are your possibilities, but what's possible in your life? And sometimes it's just one food. So if it's just one food, then we just do one food. But if they're like, look, I feel miserable, I just want to go after it, then I'm going to go with a larger elimination diet. If they've already done that work and they're like, yeah, I can't do gluten and dairy, and, they've got their list already, but they're still having reactivity, my next stop is usually histamine intolerance. If I'm seeing those mast cell mediated symptoms, my next stop is histamine intolerance, because it's usually that. We're usually stopping right there. We usually don't have to go any further than that. I see so much histamine intolerance in my practice. It's extraordinary. And it's usually that. And in which case, if it's histamine intolerance, okay, now we're looking for SIBO. Now we're looking, and in many cases, SIBO is present with histamine intolerance. So, now we're going there. But if we have to go further, and it's not histamine didn't do anything, or only came down by 20%, and we still have issues going on, Then I'm going to start assessing, and I'm looking, we're going to be running serum tryptase. We're going to be running maybe a 24-hour urinary methylhistamine. We're going to be running, those are the two that I typically will look at first. Though I will say, I so rarely see an elevated serum tryptase in this population. I keep thinking it's going to come, and it's a handful of people that have that elevated serum tryptase. And that's one of the diagnostic criteria for mast cell activation. So, if you don't have it, then all of a sudden you don't have mast cell activation, even though you are benefiting from antihistamines and dietary change and all of that. You don't have that diagnosis. I overlook that because
it's so often negative, right?
It's like, okay, because we can't just walk away from it. Well, you don't have it, therefore we'll just stop working on this. So if I'm seeing more, especially eczema, lung polyps, things like that, I might start looking at salicylate intolerance. I don't start there because that is an exceptionally difficult diet, as you know.
It is.
God, it's brutal. And it's, 6 vegetables. And
yes, it is. And if those 6 vegetables. But let me just kind of go back for one moment, because you said the 24-hour methylhistamine. How accurate is that for MCAS, diagnosing MCAS? Or is it a diagnostic test for it?
It is considered one of the diagnostic tests for MCAS. So serum tryptase, 24-hour urinary methylhistamine, or 11-beta prostaglandin F2. Those are the 3 that are considered. So one or all 3 of those needs to be positive in order to have a positive MCAS diagnosis. And these are all just, different, things that get released when the mast cell explodes, basically.
So you'd have to be in an active flare then for those to be active.
Yep, absolutely.
Right? So do you tell your patients to eat a challenging food, or does that matter, or do you just randomly test?
No, sometimes we'll usually just do a standing order for them, and then when they're flared, they come in and they take the test. Other practitioners, and I've read this, and I was reading this in an article just recently, where they basically just they do it all in the office. It's just to get a baseline, because, oftentimes they're not flared when they're in the office. I guess all of a sudden they feel great when they come to the doctor. So they're often not flared. So they'll take the baseline. So let's say you get a serum tryptase of, 1 or 2, and then put in a standing order for the serum tryptase so that when they are flared, they can come in and have it done to see if there's a difference. Because maybe you're not, 15 and above. Maybe you're going only up to 10 or 9, but your baseline was at 1 or 2. That could still, even though you're not going above that, in that zone of, high tryptase, we are seeing a difference in those numbers. And that might be enough to, give us some information.
That's a really good little clinical tip. I'll keep that in mind for sure.
Oh, sure. Absolutely. And, the thing is that even if you have that positive serum tryptase, it doesn't necessarily change your treatment protocol.
It's just a peace of mind for the patient sometimes, isn't it?
Absolutely.
And I'm like, okay, I finally know what's wrong with me. So
that's exactly right. This is mast cell activation disorder. This is what's going on. Though I have to say that most patients are, the fact that we might have them on a combination of antihistamine diets and supplementation, and they're feeling better, they're willing to say, even if they don't have that positive serum tryptase, they're willing to know this is a mast cell activation disorder. It may not be MCAS, but it is a disorder of the mast cell. Something is going on because antihistamines work. Right. So there is something going on that is triggering those mast cells, and we're not exactly sure what. And we start working at the underlying causes, but they're usually okay without the diagnosis, as long as they know that things are working and that we're working. They finally have some answers and some resolution to some of their symptoms that they're experiencing.
Well, this is so fascinating. So what about some good resources for those who suspect they have MCAS, or what kind of practitioners are really well versed? So who should they consult with?
Sure. So one of the resources, actually 2 of the resources I already mentioned, was the mastcellmaster.com. So that's Dr. Theo Harides'. That's a tough. Theo Harides. Sorry, Theo Harides.
The master, just the Mast Cell Master. Yeah.
The master's website. And then the algonaut.com is where his supplements are. But the Mastocytosis Society has excellent resources, and their website is tmsforacure.org. And that's really, I think, the best resource to go to for mast cell disease and mastocytosis, because they really do look at both there. It used to be just for mastocytosis, but since MCAS has an actual diagnostic code now, they really spend a lot of time with that as well. So I think those are your best resources outside of just going to, here in the US, we have pubmed.gov, which is where all the published research is on MCAS. But again, everything's through Dr. They call him Dr. Theo's website. It's a lot easier to say.
Okay. So could you repeat that TMS4ACure?
Yeah, 4acure.org.
And that's the number 4?
It is actually foracure.org.
Cure.org. Okay, great.
So that's a great website. As far as who do you work with? This is really challenging because as you and I both know, not a lot of practitioners know about this. I think many are getting more familiar with mastocytosis, but even just 5 years ago, most doctors did not know what mastocytosis is. And now there's this mast cell activation situation, and they still don't know what it is. So that's where it kind of falls in this crack, right? You're going to go to an allergist, and they're looking for straight up IgE allergies, and they're like, no, you're fine. There's nothing there. And then, well, maybe you should go see a rheumatologist because you do have joint pain, and maybe this is, lupus, right? All these symptoms, like blood rashing and things like that. Maybe this is lupus. So we see a lot of those patients who, maybe this is lupus. No, they're falling through the crack. No, you don't have ANA. No, nothing's really adding up there. And you're going to go to a neurologist because maybe you have migraines, but no, this is nothing they're doing is helping you. So you're going to go from specialist to specialist to specialist, and no one's going to be able to help you. And this is really a challenge because there aren't many practitioners who A, know about it, and B, can help you get through it, help to diagnose and then help to treat. So it is very challenging. I would say your best bets is to, depending on where you live, of course. So if you're in a major city, then going to your university medical centers, may be a good bet because they're a little bit more on top of the latest things happening. And like, for instance, I'm in Seattle, Washington in the US. And so we have a mast cell specialist at the University of Washington here. There's only one.
Oh, wow.
Takes till January to get in to see him because he's the only one, but at least he's aware of it, right? So, but allergist would be a good person to at least consult with, who might be able to have that conversation with you. Certainly naturopaths, I think, are going to be a little bit more on the cutting edge with that, a little bit more familiar with it, or nutritionists who specialize. But again, I don't know many who do. I have this, it's come to me through no deed of my own. It's just come to me and seeing those patterns. So there aren't many nutritionists that I know of that really specialize in that. That might be a little bit different in Australia because your nutritionists and your doctors do work a little bit more with histamine issues and salicylate issues. So they might be a little bit more on task with this.
Yeah, possibly. I think it's still a really well underdiagnosed condition. So, this is one reason why I'm really interested in talking to people like yourself who've had a lot of experience with it. I haven't come across anyone here who has had a lot of experience with it. Now, I might have not come across that person. It's very possible. But, like my thought on all of that is a lot of allergies in general are on the rise, as we know, right?
Absolutely.
So this has to do so much with not just the stress and trauma, as you mentioned at the very beginning, but, there's so many different factors that we don't really understand as to how they all influence our health in terms of pollution and heavy metals and I mean, the list goes on and on. So it's just interesting how we're all getting more toxic, so to speak. And invariably, we're going to be starting to see a lot more of these people in our clinic. When I started 20 years ago, I never saw people that could only eat 3 foods, 5 foods.
Exactly.
Never did. So now it just seems like it's a different playing field in a way. People are more sick. People are more come preloaded almost when they, So anyways, that's just my thought on that. But
I agree. Completely agree that our environment is becoming more and more toxic.
Yeah.
And I think we are in a more stressful society. So we get stress, we get the more toxins we're breathing in or taking in via our food, and that's impacting our microbiome and It's like, I think it's all really coming together. And then we have the genetic predisposition, because we don't all, we're all exposed to all of this, but we don't all have MCAS, right? So then there's that genetic piece that's tied in as well. And I was going to say, you mentioned about the environmental piece, that I have had situations with MCAS where it was the water that was doing it. It was just, it's like we did absolutely everything. And maybe we got things down by like 40%, but we still had, this certain level of urticaria or reactivity going on. And, they were drinking a ton of, how's your water intake? I'm drinking a ton of water. And I went, what kind of water are you drinking? It was just one day I was like, what kind of water are you drinking? And they said, oh, it's just, it's tap, or it's filtered from my refrigerator. I went, what would happen? Because I went to a mastocytosis conference, and this GI doc mentioned this about the water. And I came home from this conference. I said, drinking a lot of water, let's just go to bottled for a little bit. Let's just see what bottled does for you. And that was it. They thought I was nuts. Yeah, all right. And I went, okay, I'll do whatever you want. And they went home and they thought, in no way could this make a difference. And there it was. Like within a week, things were back down to a tolerable place. And it was, so as water is something that I look at, of course, and I see it over and over and over again. It's something that I look at all the time. So yes, our environment but our water sources as well, that, and the water on the skin, and some patients do best when they get a filtration system throughout their entire home. So not just what they're drinking, but what they're putting on their skin as well. So you're right. That environmental piece absolutely is a critical piece in all of this.
Well, this has been, I could just go on and on, because I have so many different thoughts also on trauma and stress and the sort of hyperactivated, sort of the analogy between a hyperactivated immune system and a hyperactivated, nervous system. It's just really interesting to me, those correlations. But alas, we're out of time. But I just, we could go on, I'm sure, for hours on that alone, right? Like just like this, because I studied a lot the effects of trauma and Peter Levine's work, the somatic experiencing and all that. So, but that is just so super fascinating. But where can people find you, just so that I have some link to your website, and also when people tune in, there will be Heidi's bio and more information will be on the SIBO Doctor podcast site. So, but if you could just mention something where they can find you.
Yeah, sure. So I'm at foodlogic.org is my website. And then I also have eliminationdiet.rd.com. And this actually has 3 different elimination diets, one of which actually speaks more to MCAS. It's the one that takes out salicylates, histamines, as well as all the other allergens. It's a highly restricted thing, but it does speak to what we're talking about today. So, and that just educates you a little bit more about what we're talking about as well.
Fantastic. Thank you so much. I might contact you again, and because it's been so fascinating, I'm sure we could talk about lots of other different topics that are related to this really activated digestive tract and what happens there. But thank you so much for your time.
Thank you. It's been a pleasure.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Head over to our sponsor, SIBOtest.com, an online testing service for your patients and home of the Practitioner Education Portal. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.